Hello, everyone. Welcome to our webinar today. Thanks for joining us. This is our Education in Isolation webinar series. I'm Abe Gardner. I'm the EMG Product Manager for Cadwell Laboratories. Today's topic is repetitive nerve stimulation, and we'll have a demonstration of technique and pitfalls by Dr. Devin Rubin and Jennifer Walcord. This is the second webinar that they've done for us. If you missed the first one, we'll be posting it on our website, so you can watch the recording of their first webinar, which was on uncommon NCS studies. Dr. Rubin is a professor of neurology and the director of the EMG laboratory of Mayo Clinic in Jacksonville, Florida. Dr. Rubin is also a member of the AANEM and ACNS and has been involved in EMG education around the world. Jennifer Walcord has her master's degree in science from the University of Florida. Jennifer has had her RNCST certification through AAET since 2008 and has worked in the Mayo Clinic Neurolab as a neurophysiology tech for the past 12 years. Both Dr. Rubin and Jennifer have opted to forego compensation for this presentation in lieu of a Cadwell donation to the COVID-19 Response Fund for the World Health Organization. We encourage anyone participating to also donate to this important cause if you're able. Donations can be made at covid19responsefund.org. You can ask questions in the toolbar on the right-hand side of your screen. We have a large audience, but I'll do my best to moderate the questions as they come in. There'll also be time for a few questions after the end of the presentation. If you look to your right-hand side of the screen, you'll see a questions box, and right there is where you can type in questions for the presenters. If you have a comment to me specifically, you can use the chat box for that if you have any questions or problems. The audio and video quality is based on your local bandwidth. So if you're having audio problems or video problems, you may want to, we are recording this and we'll be sharing the link to you at a later date. Dr. Rubin, if you could turn on your video camera, I'll explain how to interact with the software a little bit. And are you off mute?
Hello.
Great. So really quickly, before I turn the time over to Dr. Rubin and Jennifer, if you look in your screen, you should see a bar that separates the video window from the software window. You can drag that bar up and down to make either the video or the software larger or smaller as you watch the webinar. So that will allow you to see either the video presentation of how they're doing the studies versus what you're seeing in the software. You can also, at the bottom right-hand corner of the window, hit the double arrows, which will expand the screen to a side-by-side view. But I think that the vertical top and bottom view is better for watching the webinar live. And I'll go ahead and turn the time over to you guys. Thank you.
Thanks, Abe. Good afternoon to everyone watching, or morning or evening, wherever you are. I'm Devin, as Abe said, and this is what I look like without a mask on. This is Jennifer.
Oh. Hello.
We're coming to you from our laboratory at Mayo Clinic in Jacksonville, Florida. Obviously, in the current times, our policy is that everyone should be wearing masks when we're at work, so we're going to be presenting this webinar with a mask on. Hopefully, you'll be able to hear everything well during the session. So the goal of this session is to demonstrate repetitive nerve stimulation, and we hope that during this hour we can teach you a bit about how we perform repetitive stimulation. We'll demonstrate a couple of different nerves. We'll talk a little bit about why we do it and how the procedure and the protocol that we use in our laboratory as well. However, before we start with repetitive nerve stimulation, we want to review one nerve conduction study that we demonstrated at our last webinar. And we're not sure how many of you actually have observed or were on the live webinar when we demonstrated uncommon conduction studies. If you were, you might recall that the first conduction study that we performed was the dorsal ulnar cutaneous nerve. And it wasn't that easy. We showed that nerve conduction studies aren't always that easy. I have really good nerves, and it was hard to get my duck. Wouldn't you say it was kind of challenging? And how did you feel after the webinar?
Drained.
Drained and frustrated. We were both like, thought, this doesn't make sense. I should have really good nerves. And we understand that there were a lot of comments that weren't read to us, and suggestions and chats and tips that people were sort of sharing. And some of you may have shared some of those tips. But we were bothered by it, and what we did is the next day we came back into the machine and we used ultrasound, and we followed my ulnar nerve, and we found the dorsal ulnar cutaneous branch coming off of the ulnar nerve. And what was interesting is in our lab and in many labs, we're very strict on our distal distances. So we have set distances for many of our nerves. And that's important if you're using a distal latency measurement. You have to have very precise distances. And in our lab for years, the distance that we stimulate the dorsal ulnar cutaneous nerve relative to the G1 electrode is 8 centimeters. In fact, some textbooks say 10 centimeters. So we always measure 8 centimeters from our G1, and that's where we stimulate. Well, when we came back to and looked at the nerve with the ultrasound, we found that the nerve at 8 centimeters is way underneath the flexor carpi ulnaris tendon. And it isn't until just about the ulna styloid process that the nerve pops out from around that tendon. And that distance is at about 6 centimeters from the G1 electrode. So we went back and we re-stimulated at 6 centimeters, and the nerve came in very easily. And we did the same thing on Jennifer, and the same thing at 8 centimeters, it was very difficult to get the nerve. At 6 centimeters, it popped right in. So we want to just demonstrate that real quickly, just to show you very quickly before we get into repetitive nerve stimulation, how difficult it is at 8 centimeters and then how easy it is at 6 centimeters. So we're going to quickly do a dorsal ulnar study. So Jennifer's measuring, what are you measuring? 6 and 8? Okay. The other problem we had, which will not be fixed, is I have a hard time relaxing my hand. So I'm trying to relax.
All right, so we're going to start at 8 centimeters.
And part of the problem, and this is what we have, I'm not totally relaxed, but also at 8 centimeters, we're stimulating the ulnar nerve itself. And actually, it popped right in. So of course, it disproved everything we just said. But I think you're a little bit more distal than
sliding,
you were.
I think. Yeah.
But if you see, if you stimulate right at the radius styloid process, maybe just.
I think I started sliding. I think that's why it came in.
Yeah. And that's all me there. And there's the dorsal ulnar cutaneous. Right there. So it pops right in.
Right
you can see at 9, she's only giving me 9 milliamps. And if you go more proximally, so just go about 2 centimeters proximally, a little bit further proximally, right there. So that's at about 8 centimeters, and it just goes away. You can't stimulate the nerve. It's underneath the tendon, and it's with the ulnar nerve. So just to follow up for those of you who do dorsal ulnar cutaneous conductions, that it's more ideal to stimulate closer to the ulna styloid process rather than more proximally in the arm. And you can, if you have ultrasound, it's kind of neat to see that nerve. It's a very tiny nerve, but you can see it pop out underneath that tendon. So anyway, the main focus of this is going to be repetitive nerve stimulation. And before we begin demonstrating, I wanted to just show 2 or 3 slides on repetitive nerve stimulation. And we don't know your experience. Maybe some of you do this very routinely. Maybe for some of you, this is a new technique. You haven't done many repetitive nerve stimulation. So basically, the concept of repetitively stimulating a nerve, the whole purpose is really to stress the neuromuscular junctions. And that's what stimulating the nerve at slow rates does. It releases acetylcholine, it depletes some of the immediately available stores of acetylcholine, and we look to see what the response of the CMAP waveform is each time we give a shock at 2 or 3 hertz. And I'll show you a slide or two what happens in a normal person, and then I'll show you a slide of what happens in a patient with myasthenia gravis or Lambert-Eaton myasthenic syndrome. One of the important points that we'll demonstrate is that this is a technically difficult study. And it's certainly technically difficult if you're performing this by yourself. If you're a technician or a physician who you're by yourself, it's hard. All the technical factors that come into play with routine nerve conduction studies come into play with repetitive nerve stimulation, but also you're giving multiple shocks and everything has to remain perfectly still. And if it doesn't, then it can lead to false positive or false negative results. And that's what makes this a bit challenging. And once you say it's in a lot of patients, some patients it's not too bad, but some patients it
can be difficult.
Can be difficult,
yes.
Yeah. We're fortunate sometimes we have 2 techs in a room and it makes it a little easier, but many times you're probably by yourself.
Yes.
Yeah. So just to give you a sense of what we're doing, why we do this, or what happens physiologically, and this is not going to be a lecture on physiology, but I think it's important to understand that when we stimulate a nerve or a neuromuscular junction at slow rates, and that can be anywhere from 2 to 5 hertz. In our laboratory, we use 2 hertz, some labs use 3 hertz, but anywhere between 2 and 5 hertz. When you stimulate a nerve multiple times, this is what happens conceptually with the acetylcholine release, that with each shock, there's less quanta of acetylcholine that are released, at least to about the 4th or 5th shock, and then it kind of levels off and it might actually increase a little bit after more stimuli. So this is what's happening to the acetylcholine. And remember, what we're recording are action potentials, and that relies on the end plate potential at the muscle. And when you're depleting the acetylcholine, when you're releasing less acetylcholine, the end plate potential actually reduces. But in normal people, the end plate potential lowers, but if it's so large that each time we give a shock, the end plate potential reaches the threshold for depolarizing the muscle, then we generate a muscle fiber action potential at each junction. So that's normally, we have enough reserve or enough of a safety factor that we can deplete acetylcholine, but we can still generate an end plate potential and an action potential. And then if we're doing that at all of the junctions in that one muscle that we're recording from, then the summated compound muscle action potential, which is this CMAP or the M wave, looks exactly the same each time we give a shock. So there's no drop in the amplitude with each shock, even though we're reducing the amount of acetylcholine released. So that's normal. That's what we want to see when we perform repetitive stimulation in a normal person. We don't want to see a change in that response. Well, what happens in disease is that, particularly myasthenia gravis, which is much more common than presynaptic neuromuscular junction disorders, but in myasthenia gravis, we have the normal amount of acetylcholine. So with each shock, there's normal acetylcholine, but the acetylcholine is reduced, and that will reduce the end plate potential. But what's different than a normal person is the end plate potential already starts out low because the acetylcholine receptors aren't functioning or they're blocked by the antibodies. So if we give it one shock and the end plate potential reaches threshold, we generate an action potential. If with the next shock, the acetylcholine is reduced, but it's sufficient to reach threshold, we again generate an action potential in that muscle fiber. But then the next time, maybe it doesn't reach the threshold, so no action potential is generated with subsequent stimuli. And if that's happening at multiple junctions, then the summated CMAP decreases with each shock, and that's called decrement, and that's what we're looking for when we're performing our repetitive stimulation. We're looking to see, is there actually a drop in the CMAP amplitude? And that's the concept of how decrement actually occurs. So we can discuss this after we demonstrate, and there may be some questions about this, but the one big question often is, well, what's abnormal decrement? And really, in a normal junction, in a normal muscle, 0% decrement is expected. Shouldn't have any decrement in a normal junctions. But there's technical problems, and often there's a bit of instability of the baseline. There may be a little patient movement, a little stimulator movement, and that slight change in the CMAP can lead to a drop in amplitude. So a conservative or a general criteria that's typically used is a decrement of over 10% between the first shock and the last shock, which in our lab is 4, the fourth shock. More than a 10% decrement is abnormal. That's not a set rule. And if you have consistent decrement of less than 10%, if you have 8% or 7%, or some studies have suggested 5% decrement, if it's technically reliable and it's consistent, that certainly could be abnormal. But most labs will use 10% to feel comfortable that it's not a technical problem. The other point that with respect to decrement is when we're giving stimuli, 4 stimuli, the largest drop in amplitude in disease is between the first and second shock. So this is a patient, comes from a patient with myasthenia gravis. So the amplitude drops significantly, almost by 40% here. And so the largest drop is always between shock 1 and 2, and then there's less of a drop, and eventually it'll sort of level off and may actually improve. If you give 7 or 8 shocks, then there might be a little bit of improvement in the decrement. If you have a pattern where the largest drop is not between shock 1 and 2, or it goes down and up and down and up, then that's a technical problem. And we're going to try to demonstrate a few technical problems that might look somewhat like decrement. So that's the concept. Just one last slide, which comes to play in patients where we suspect have Lambert-Eaton syndrome. If you stimulate at fast rates, or you have the patient exercise strongly, then what happens is the amount of acetylcholine that's released actually increases. So if the end play potential starts out low because there's not enough acetylcholine that's being released with the first shock, and you stimulate at fast rates, the amount of acetylcholine increases, the end play potential increases, and what initially is no response then becomes an action potential with, again, with fast rates over about 10 hertz, or if you exercise the patient, that's the same thing as stimulating at 10 or 20 hertz. So that's where we get an increment or a facilitation of the response. So that's the lecture part of this. That's the concepts of this. And what we thought we would do is we would start off and demonstrate some of the common nerves that in our protocol that will often perform repetitive nerve stimulation. I would say, what do you think? The most common nerves we do are what?
Probably spinal accessory and facial.
Spinal accessory and facial. So we'll demonstrate both of those. And that's because in myasthenia, proximal nerve muscle combinations have a higher yield than distal ones. And particularly if someone comes in and they have symptoms of just bulbar weakness or diplopia, the likelihood of finding abnormalities in a more distal nerve is going to be fairly low. We often do ulnar, and sometimes we'll do a perineal or anterior tib also. How often would you say you start with an ulnar, or what situations? Yeah. Sometimes if a patient's sent just for weakness and the index of suspicion is fairly low, that the patient has myasthenia, we may do our routine conductions and just do a baseline rep stim on the ulnar, just as sort of a screen to make sure we're not missing something obvious. It's easier to perform distal nerves. It's easier to stabilize the hand. And so even though the yield is lower, we often start with a distal nerve and then go more proximally. So you want to start with an ulnar?
Mm-hmm.
We have one question while you're getting set up there. The question is the decrement of 10% applied to facial nerves as well, or is 20%. Should 20% be considered for those nerves?
I would say so again, I would not say, I don't like using a set cutoff, but I would say that if someone on facial nerve had consistent 10% decrement that looked reliable with a stable baseline, and even if it was 8%, we just did a study of our series of patients and found that consistently, if that there were a number of patients, if you used 7% in any nerve, the sensitivity increases and without a significant reduction in specificity. So I would certainly not set a cutoff of 20% decrement in the facial nerve. I think that's too high, and in mild cases, milder cases, you may call that a false negative if you use a 20%. But I think the key point is the decrement has to be reliable, and we often will perform several sets at rest before we have the patient exercise to make sure that the same amount of decrement is occurring with each set at rest. If you have a decrement of 12% and then 10 seconds later or 30 seconds later, the decrement is 0, that should raise a red flag that there's a technical problem. Okay, so you want to...
Okay.
I'll put this down.
Okay, so we're going to put G1 over the belly of the ADM. Spread your fingers out wide. Okay, there's G1, and G2 is just at the base of the 5th digit. Let me bring your arm up. So we're going to measure 6.5 centimeters approximately to where we would activate the ulnar under the flexor carpiolaris. Okay, but we perform the rep stem with the arm down.
So that's when we perform our standard ulnar study, our routine ulnar study, we perform it with the elbow up. And sometimes, I mean, would you say if you're just kind of screaming and the patient's cooperative, you're just going to do a baseline? I know I'm contracting here. You're just going to do a baseline set of rep stem. Do you always bring the arm down?
No.
Or do you sometimes do it with the arm up?
Yes.
It really doesn't completely matter if you do rep stem with the arm up or down. I think the arm down is we're going to show you ways you can stabilize the muscle. And it's important because you want to make sure that the patient's not moving when you're stimulating. So it may be a little bit easier with the arm down to stabilize the hand.
So this is something that we used to use to keep the hand immobile. We don't really use it too much anymore.
We're not going to use it here just so you can see everything, but.
So the hand would go in, and there's a sponge here at the bottom. And you would just kind of attach it over here.
And our guess is that none of you have this type of board, so we're not going to demonstrate with the board.
So we kind of have a little resistance we're going to put around the fingers. It's just Velcro.
Yeah, make it tight. And this can be helpful when you have the patient exercise. You can also use your hand, but if you're performing the rep stem by yourself, you need really 4 hands. You need to be running the machine, you need to be holding the stimulator, and if the patients can, when they contract, we do an isometric contraction. You don't want them spreading their fingers because that might move the G1 electrode relative to the end plate, and that can change the morphology of the waveform. So you want everything perfectly stable. So you want to give them resistance when they're exercising, and this Velcro is a nice way to give them some resistance.
We have a question. Would you do a 10-second exercise after every baseline with or without decrement?
Let's hold on that question for a moment. We'll come back to that in a moment. We're going to show baselines and then we'll talk about exercise.
All right, so I'm going to go ahead and bring in the ulnar. You feel anything?
Now I am. So Jennifer's sliding around trying to be nice to me so she doesn't overstimulate. And just to make this demonstration harder, my ulnar nerve lies right underneath my tendon, my FCU tendon, which also makes it technically a bit more difficult when you're doing rep stim. Remember, anything that moves the stimulator away from the nerve is going to change your amplitude.
Right, and that's true. I've found that I'm right underneath the tendon right now. So I'm going to bring up the stimulus to make sure I'm super max, because if I do end up moving away from the nerve a little bit, I want to make sure that I have enough stimulus to still completely depolarize that nerve. So we're going to make sure of that. And here we're 11.97, 13.13, still going up.
This is an important point. So before you give the 4 shocks, I'm going to reiterate that. If you're submaximal or you're just at threshold of maximal, when you give a shock, if I move, the patient moves or the stimulator moves a little bit, the current may not depolarize all the axons, and that's going to drop the amplitude. So you really need to make sure you're supramaximally stimulating the nerve. Now you could argue, well, why don't we just give 100 milliamps and then we know we're supramaximally, but you also want the patient to be comfortable because you're going to be giving multiple shocks. You don't want to give too much stimuli. But once you think you're maximal, go up another 5 or 10 milliamps, give another shock to make sure you're truly super maximal.
So we're going to continue to go up. Okay, I think we've reached, we've got the whole nerve depolarized now. So we're going to go ahead and give a train of 4. Okay, we're going to give another set of 4.
So before you give a set, what we're looking at is we're looking at the baseline. So you can see there's a little arrow, the onset marker. We're making sure the baseline is very stable, that the markers are placed appropriately, which they for most nerves, they're pretty accurate. And then we're looking at the morphology to make sure the morphology is not really changing there. And then if you look at you can see each amplitude in a bar format up at the upper right. And then the percent decrement, percent change is right there. Jennifer's showing you it's 0.7%. So it actually, so it's basically 0 or 1% if you round up. Okay, and so we're looking, and we're visually looking at the pattern also. Here, there's no decrement, but if there was, I would look at the pattern of the drop in amplitude.
Okay, here comes another set.
So again, really no decrement.
And again, we always do 3 sets. Now my patient moved.
So if you look now, I purposefully moved, but if you look, if you simply look at the bar graph, you'd say, oh, look, there's a drop. And that drop is 10%, right? So that's abnormal. It's above 10%. So I must have myasthenia gravis. But the pattern is not correct. There's a couple clues here. The biggest drop, as I said, should always be between the first and second shock. Those two are exactly the same. If the biggest drops between the third and fourth, the third actually goes up. And then if you pay attention to the waveforms on the left, you'll see the morphology of the waveforms are slightly different. The third one's a little thinner. They all look a little different. In fact, if you can superimpose that or no? overlay. It's, yeah. If you overlay it, you can see the waveform morphology looks different. So that all of that is a clue that there's a technical problem. And either the stimulator moved or the patient contracted and or something like that.
One question is it better to use a bar electrode as a stimulator to avoid changing the stimulation point of the cathode?
It's debatable. I would say no, because the bar electrode can move just as much as a stimulator. In fact, Jennifer's holding the stimulator pretty tight. Her thumb, you can see her thumb is bracing that stimulator. She's pushing in, so the stimulator is closer to the nerve. I think if you have a bar electrode and there's movement, that bar is going to slide. And there's more of a risk, in my opinion, there's more of a risk that you're going to have movement. Okay, so we would do 3 baselines, and then would you have the patient exercise?
If there's decrement or there's a strong suspicion of myasthenia or Lambert-Eaton, then I would do 10 seconds. Mm-hmm.
So this is, the question is when do you exercise? How long do you have the patient exercise? And the answer is often to these questions is it depends. So if I'm gonna pump this up to see, you can see me talking here. So if you suspect, if there's a high index of suspicion that the patient has myasthenia gravis, exercising for about a minute will often deplete more acetylcholine and lead to post-exercise exhaustion. So the amount of decrement should worsen at 2 or 3 minutes or 4 minutes after exercise. So if we're looking for that, in some cases, if the decrement doesn't reach, say, 10%, maybe it's 8%, you exercise them and then it goes up to 12 or 15%, then you might be more confident that the patient truly has a defect of neuromuscular transmission. If we think that the patient might have Lambert-Eaton syndrome, that's where we're not really looking for post-exercise exhaustion, but we're looking to see if the amplitude increases, just the CMAP. So we're looking to see for facilitation or increment, and you're going to see that with 10 seconds of exercise. So if we suspect that, then we will do 10 seconds of exercise. I think the question was, well, what if you see decrement? So let's say we see a decrement here of 12%. What do we do? Do we do 10 seconds or do we do a minute? Part of that depends on the CMAP and our suspicion. If the patient comes in because they have leg weakness and they have hyporeflexia, they've had lung cancer, and we suspect Lambert-Eaton, then absolutely we're going to exercise for 10 seconds. In other words, in contrast, if the patient comes in and they have diplopia and slurred speech, they have 12% decrement at rest, we probably don't need to do 10 seconds of exercise to see the repair of the decrement. You probably could just do a minute to see if there's post-exercise exhaustion. So it just kind of depends on what you're looking for.
Yeah, so we had a question. So there is no fixed protocol, or do you use a fixed protocol?
I don't like using a fixed set protocol. I think we have a general algorithm, and our algorithm is if we have low index of suspicion for anything, then we just do baselines. If we have a suspicion for myasthenia gravis, then we will exercise for a minute. Baselines, then 3 baselines, then exercise for a minute, and then stimulate at 30 seconds, 1, 2, and 3 minutes. And that's regardless of whether there's decrement at baseline or not. If there's decrement at baseline and we're in the CMAP amplitude's low, or we have a suspicious index of suspicion, then we would do baseline 10 seconds. And then we might then go on and do a minute to see if there's exhaustion. So that's the general approaches. That's not set in stone for each patient, but that's kind of the general algorithm that we use. Did I get that right?
Yes.
Yeah. Okay. So here, like, let's say that there was a suspicion that maybe I had myasthenia gravis and we were going to exercise. Then what would you tell the patient to do?
All right, so I'd have the patient spread their fingers wide apart and
We can turn the volume up. So you probably can't hear that, but you can hear how well the patient's exercising. And I'm not going to exercise for a whole minute just for the sake of time, but we usually have them exercise for about 20 seconds or 30 seconds, take a 5-second break, and then do it again. And then.
okay, then we turn down the volume because it'll be loud. We're going to do 4 shocks.
So pretty stable.
Mm-hmm.
And then we would wait 30 seconds. We would do another set. We can do it. Go ahead. And then we would wait another 30 seconds. So at a minute, we would give another set. And then we usually take this out to about 3 minutes. And you can see here, it's pretty stable. It's not perfect. It's not 0% decrement. It's about 1% or increment even. So there's a little bit of baseline movement. But that's why we want to see a consistent, similar degree of decrement to be confident that it's real.
Mm-hmm.
So a couple other technical things that might occur. So maybe back down on your stimulus intensity to like 20. Yeah. So Jennifer's going to go down to a lower stimulus intensity, and let's just shock here at maybe submaximal. Okay. So a couple things here. So you'll notice that still looks pretty stable. Doesn't look too bad, but the amplitude's lower. So if you look at those green bars on the right compared to the blue, the amplitude's lower. So she's probably not super maximal. Now here it didn't make a whole lot of difference, but if I were to move, or maybe if she slips a little bit, let's just see what happens. So maybe just slide just a little. So there, she purposefully slid off the nerve, and that can happen. The patient may move, pull away, and there, look, there's 100% decrement that goes to 0. And that's obviously technical, but even if you had a 4th stimulus there, if you had a 4th shock, you should know that it's a technical problem because the largest drop is between stimulus 2 and 3. Should be between 1 and 2. So just another example that if you're submaximal, more movement by the patient or whoever's stimulating can lead to false decrement. We can show one more set here. I'll move, yeah.
Okay.
So there, now I just developed Lambert-Eaton myasthenic syndrome. So my amplitude went up. I was pulling away a little bit, but for some reason I must have been, when I was pulling, the stimulator might have even moved closer to the nerve when it was farther away from the nerve. So there's a lot of technical problems. If you're not holding still, if everything's not held still, then you can see changes in the amplitude simply related to muscle contraction or not stimulating the nerve appropriately or completely. So we're going to demonstrate, so that's a fairly easy nerve to perform repetitive stimulation, but the yield is going to be fairly low unless someone has a pretty severe neuromuscular junction disorder. You may not see any decrement on the ulnar. So we're going to go up and demonstrate the spinal accessory. It's going to be a little bit hard to, I'll turn so you can see where we're actually putting the electrodes. We do these with the patient laying down, although I think some labs might have the patient sitting up.
So G2 is going to be over the acromion. And then G1 is just going to be over the trap, which is halfway between C7 and the acromioclavicular joint. Okay, and then we're going to put the ground between G1 and where we would be stimulating behind the sternocleidomastoid. Okay.
Do you want to hand me
Yes.
the band?
Oh, that one.
Thanks.
Thank you.
So the spinal accessory nerve is actually a fairly easy nerve to stimulate. If you don't do these very often, it doesn't require much current. The nerve is superficial, so it doesn't hurt that much. It shouldn't require a ton of stimuli. I think what's hard about rep stim is that it's hard to stabilize that muscle. And we're going to show you what we're going to do. Jennifer's going to do baselines, and then I'll exercise. We have bands that we sometimes use. So these are just those exercise bands. And what you can do is you can put this, let's see if I can show, you can put this around the patient's foot, and then they can grab on. You can't really see this, but I'm grabbing on here. I'm grabbing onto this, and I'm keeping my arm straight, but I'm going to use these bands when I exercise. I'm going to shrug my shoulder up by keeping my arm straight. You can point it towards here, towards my shoulder. So I'm going to shrug my shoulder up to exercise. That still won't keep the muscle perfectly stable. It's still going to move when she stimulates. So that's where it's really important to hold the stimulator as steady as possible. But this is a way that'll allow me to exercise that muscle. If you use these bands, and you can even use a sheet and tie it in a circle, you want to make sure the patient's not flexing their elbow. They want to be contracting the trapezius. So you have to tell the patient, instruct the patient, don't bend your elbow, but shrug your shoulder to exercise. So I'm going to keep this on. Not going to exercise yet. We'll just demonstrate the baseline first.
Oops. Okay, so just slightly bring your head up a little bit. Okay, and then relax. All right, so we're going to start. And I'm going to slide to make sure I'm in the best place over this nerve. I'll slide again. I'm going to go back. Okay, and now I'm going to make sure I'm super max. I'm going to increase the stimulus. Okay. So now we're going to go to a train of 4. Here they come. We'll do.
How's it look? I can't see, but
My patient moves, so I can't guarantee it's going to look good the next time. Looks pretty good. Here they come again. Okay, looks good. We got 0.3 decrement on the first one.
So you want to do another baseline?
Yep. Here comes another one.
Okay, so then I'm gonna exercise, and I'm gonna shrug my shoulder and just watch Jennifer's hand. She wants to try to make sure that stimulator stays on that nerve and is not sliding off. And it's hard to really exercise that muscle. You know, it's just a tough one.
Yeah, you have to turn the volume up pretty high so you can hear the rumble of the muscle.
Okay, I'm gonna pretend that's a minute.
Okay, here they come again.
She said, oh.
Yeah. You have myasthenia.
So
You have a decrement
good
of
example there.
32%.
You don't want the patient to get up and move in the middle, but I want to see that. So a great example of a technical problem that looks fairly close to what real decrement would look like. If I was looking at that, I would still raise a suspicion if I just looked at that one set without the other three, that there's the biggest drop between shock 1 and 2, and then a little bit less, but then a bigger drop between 3 and 4. And that should be a little clue that there's a technical problem. It should be more of sort of almost a U-shaped or a ski slope shaped. And so that suggests that there might be a technical problem. And then the reason we have the baselines, and you can see the first shock, the amplitude dropped, right? So she slid off my nerve because I was moving and contracting. She slid off the nerve, and so now it's submaximal. And then with each shock, the whole trap moves and the stimulator sliding off the nerve. So that's another reason to make sure you're really super maximal here. So we can try to do that again, see maybe.
While you're doing that, we have a question about the exercise. The question was, would you do 10-second exercise to look for repair after every decrement seen in baseline, or 1-minute exercise? And then a follow-up question is, if you see proper decrement in baseline, would you continue a 1-minute exercise to look for exhaustion? If so, well, answer that, and then I'll ask the follow-up.
Yeah, those are really good questions. So personally, I don't find it all that helpful to see repair of decrement. So for those of you not as familiar, if you exercise for 10 seconds, that mobilizes more acetylcholine, and that will lead to some improvement of the decrement called repair of decrement. So if the decrement's at 12% at rest at baseline, you exercise for 10 seconds, in someone with myasthenia gravis, the decrement might go up to 5%. It might improve temporarily. The reason that might help you is if you want to be sure that the decrement is real. So it shows a physiologic phenomena that if there is repair, that makes you more confident that it's a real decrement. If I'm confident already, it doesn't add anything to the diagnosis or interpretation. So I don't think it's as important to always show that. That's just how kind of I think. But there's nothing wrong with doing that, to do 10 seconds and then do a minute after that.
And that was the follow-up question, is would you do 10 seconds first, followed by 60 seconds, or the opposite, 60 seconds first, followed by 10 seconds?
No, I would do 10 seconds first. So I would do 10 seconds and then do 60 seconds after.
Okay. And then a question on electrodes again. Have you ever used sticky electrodes for better stabilization of the stim electrode?
Have you ever used that? Put stickers to stimulate?
I feel like that would still be really hard. I mean, the biggest thing is we make sure the patient doesn't move their neck or their face at all. Yeah. They don't move their head, because the skin can move over the muscles and the tendons and the nerves. So if you've got electrodes just floating on the skin, they can easily move.
Yeah, I think it's the same issue as the bar electrode. I think it's probably worse with sticker electrodes, because they're moving around, they're sliding, that skin's sliding, the muscle's moving, and I think there's more of a risk of not stimulating the nerve. The other question I think you asked, and maybe the prior question, is what happens if the patient has 20% decrement at rest? Do we then need to exercise for a minute to show post-exercise exhaustion? The answer, in my opinion, is no. It doesn't add, if they already have definite, unequivocal decrement at baseline, to show that it goes from 20% to 25% doesn't add anything. We actually published a study a number of years ago showing that exercise in most nerves doesn't add a whole lot. It's fairly uncommon for someone not to have 10% decrement at baseline and then exercise pushing it over 10%. It's not zero, so we still do exercise them if it's mild decrement or borderline decrement. But if they have obvious flora decrement at rest, we don't always really need to exercise to worsen that decrement. So let's do the trap one more time.
Okay.
So what would you do if that happened?
I'd actually turn down the intensity. So we were shocking at 7 instead of 15. But if I was
Oh, you turned it down on purpose. Oh, okay. You were sneaky. So that went normally how she was tricking.
Right.
Yeah.
So we're back at the original stimulus amount. So what we would do if we felt like we had slipped off the nerve is we would go back to single. Just go up to this. Oh, of course I can't get it up now.
You can go to just do train.
Okay, we'll do a train. Here they come. Oh. So now you can bring up the single. Okay, so let's say we were off the nerve here. We can go back to single and then we would slide around. Till we were back where we wanted to be, and then we'd go back to train.
And then what I'll do is I'll exercise again. And let's see what happens without decreasing the stimulus. So again, watch Jennifer's hand. She's holding it very stable. So I would do that for a minute, then I would relax. How's that look?
That's good. Yeah.
So
1.1.
very stable. And then we would take that out. Again, depends on the situation, but we would take that out to a minute and then 2 minutes and 3 minutes. So that's the spinal accessory. That's a good nerve to learn to do repetitive nerve stimulation. It's a proximal nerve. It's going to be a higher yield in myasthenia gravis than the ulnar. And it's technically tough, but not that tough. It doesn't require a lot of stimulus. And I think one of the other pitfalls just in general with the spinal accessory nerve is people don't slide around to find the nerve. So if I see a study and it's required 100 milliamps to stimulate the spinal accessory nerve, either the patient's got a huge neck with a lot of muscle, or whoever performed that just didn't slide around to find the nerve.
A question that in many centers in Europe, they use 10 trains instead of 4 trains. Why do you use 4 trains of stimulation?
Yeah, so another good question. So the largest decrement, the maximum degree of decrement is going to occur somewhere around 4th to 5th or 6th stimuli. After that, the amplitude is going to start to increase a little bit. And so we do it more to reduce the discomfort for patients. It doesn't worsen we don't see more decrement with more shocks. Now, the counter argument is that if you see some improvement, so the big decrement and then it gradually improves, that would make one feel more confident that it's physiologic decrement, that it's real. And there are some studies showing that in myasthenia gravis, there will be with 9 or 10 shocks, there will be that repair, that improvement. With Lambert-Eaton myasthenic syndrome, there'll be the decrement and then it doesn't improve, it stays low. In fact, I have a slide. Let me just quickly show you this because it's a good question. Let me find the slide here. Here.
So this was, I think this study was from Duke. So with Don Sanders. So this shows no decrement. In myasthenia gravis, I think they gave 9 shocks. You see a big drop. Here's the maximum decrement. And then there's some slight improvement of the decrement of the amplitude with when you give more stimuli. In Lambert-Eaton syndrome, that doesn't improve. So that there may be a benefit in giving more than just 4 shocks. But if you're looking for just simply whether there's a decrement and what the maximum decrement is, you really only need 4 or 5 stimuli to do that.
And I have a question about it. It's a question about the facial nerve. It says we have problems in examination of children and we lose facial nerve examinations because of crying and very difficult examinations of the spinal accessory nerve. Can I use femoral nerve since it's proximal too and relatively can be stabilized?
Well, so that's a several part question. You can, first of all, you can use any nerve that you can stimulate and that you can stabilize. So you could use, theoretically, you could use any nerve, any motor nerve. So absolutely you can use the femoral nerve. And if in pediatric patients you can stabilize and they're not tensing up the muscle. So that, I guess that would be my question is, are they, are they, if they're crying, are they shaking their legs and moving around, which would lead to some technical problems. But you could use it. In adults, I think the femoral nerve is more difficult because it's harder to stimulate the nerve. In fact, if we do a femoral motor conduction study, then we often will use a monopolar needle, or sometimes we'll use a monopolar stimulator, or sometimes we'll use a monopolar needle to stimulate the nerve. So I think it's a more difficult nerve to perform rep stim on adults. We don't do it a lot on pediatric patients, so it may be a bit easier if they're thin and don't have as much musculature. But yeah, and in fact, there's some evidence that the femoral nerve is a better nerve in patients with suspected Lambert-Eaton syndrome. We're going to demonstrate the facial nerve. I think we have time, right? We're good. Yeah, we have time. So we're going to demonstrate the facial nerve. It is an important nerve. Again, myasthenia gravis often it affects bulbar muscles alone without limb muscles. I won't be crying, so I can't demonstrate crying, but you will see how this can be kind of difficult. And I am going to unmask for this one because we have to get to my nasalis here.
So G1 and G2 are over the nasalis, which is right directly under the pupil, about 1 centimeter above the nares. And we put the ground on the chin, and I'm going to kind of put it to the side here. Avoid the facial hair.
One of the difficulties I think with this is that in many people, especially older patients, the amplitude's low. The facial, we record nasalis, you can record over orbicularis oculi, but it's a low amplitude and there is often movement. You can't stabilize this muscle. So there may be some baseline sway that makes it a little bit more challenging to interpret mild decrement.
So we're going to stimulate the nerve around the earlobe. And I'm just going to slide to try to make sure I'm in the best place before I raise the stimulus more. Okay. It looks small, but it's actually a pretty good response. It's 2.25. I'm going to bring it up some more. Okay, that's pretty good. That's 4.09.
That's the best nasalis response I've ever seen.
Okay, so we're going to give 4 shocks here. And they look good. 0.5% actually increase. Here comes another 4. Zero.
And then I'll exercise. So to exercise, we have them scrunch their face up.
Here they come. So went up a little bit, 3.9.
So again, we would take that out. We don't need to, we can do one more.
We'll do a few more sets. You
It's
did
always good to make the patient
stimulator
laugh
for me
too.
last
That
time, so
adds to the exercise.
here we go. Yep, looks nice.
So it is a bit more uncomfortable for patients. And I think there are a couple pitfalls with respect to the facial. One, again, is you can't stabilize the muscle, so there could be movement, especially if the patient contracts during the shocks, which they do more, I think, than other nerves, wouldn't you say?
Yes.
They kind of tense up. The other problem is you have to be careful that when you're stimulating, if you overstimulate, sometimes you actually can depolarize the masseter. And that can be a little bit tricky because you're trying to get a maximum CMAP. And then if the morphology changes, you may be adding in the masseter response. So you kind of have to watch the jaw too, the face, and make sure the jaw is not contracting, because then you're not sure if everything you're getting is a true facial response. And so that can be a little bit tricky when you're performing this nerve for repetitive stimulation. But those are the main nerves we do. We also, if the patient has leg symptoms, we may do the anterior tibialis or the peroneal EDB, although the yield of the EDB is probably lower than, it's a very tiny muscle. It's sometimes atrophic. But we may do that. We rarely do the femoral, but certainly can do that, the femoral. Some people will do radial rep stims, either recording from EIP or the anconeus. Again, nothing wrong with doing those. I think the radial nerve is a tougher nerve to stimulate, and there may be hard to stabilize the arm from extending, so there are going to be the same technical problems with that nerve. So any questions, comments, suggestions?
There's one question here. Is this study, there's a slight stimulation artifact. How would you correct the stimulation artifact in this study?
You want to take that one? You're talking about, I'm going to come over so you can see.
You mean muscle artifact?
I think you're talking about.
A stim artifact is what the question was.
Sure. Let's bring that chair over so we both can get in. I think that the question's relating to this here, right? So you can't, so the stim artifact's actually cut off. You don't see the stim artifact there, but what you see is you see a positive dip. And that's very difficult in this nerve to get rid of an initial positivity. If you think about motor conduction studies, you don't want to have an initial positivity, right? That means you're not over the end plate. So we want to avoid that, particularly if we're assessing performing rep stim. And when you're recording over the nasalis here, there's other muscles that are depolarizing. So the orbicularis oculi probably, and you're not over the end plate of that muscle. So that's probably why it's typical to get a positivity on the nasalis. There's no way to get rid of that. I mean, you can move the electrode around to try to get rid of it, but many times you still have a positivity. What'd you say?
Right, I mean, unless it's really bad, we don't generally move it because then you have to shock over and over and over again. And this is it requires a lot of stimulus at the ear and it's painful. So we try to minimize that.
I think if you have that positivity, you want to make sure these markers are at the same spot on every trace. So here they are, but if you're not sure, you can move the markers. You want to avoid something like this, where the where this marker is at this peak positivity, but this marker is not, because if these markers are over here, now all of a sudden, look, there's decrement. So, the systems are good, they mark appropriately, but if you don't have a gray baseline, sometimes those markers could be potentially off. So you have to be careful about that.
We had a question from Eric Stahlberg, who did a webinar for us last week on quantitative EMG. He's wondering if you use the deltoid muscle.
Hi, Eric. It's good to get a question from you. We don't. I know a really good laboratory in Uppsala, Sweden, who has published a paper saying the deltoid has the highest yield. And that certainly may be true. I don't know if it was that paper or not. I think it was a different paper that also showed that the deltoid has more technical problems. And in fact, I think I have a slide showing that, but that in one study, that nerve had to be repeated more often because of technical issues. So we don't routinely do that. We usually stick with the spinal accessory. If the patient is weak in the deltoid, and that's a weaker muscle, then occasionally we would perform rep stim on that. You also can perform it on the biceps too. But I think because of technical problems when you're stimulating Erb's point, all the muscles in the upper trunk are moving, and it's a bit harder to stabilize that muscle.
A couple other questions, and then we'll wrap it up. How do you diagnose LEMS with repetitive nerve stim?
Yeah, so I'm gonna jump here to a couple slides here, just to show you. So if I can find it here, here we go. So in Lambert-Eaton syndrome, first of all, there can be overlap between myasthenia gravis and Lambert-Eaton syndrome. So it's not black and white. It's not always obvious. With Lambert-Eaton syndrome, you can have decrement at baseline. You typically do. Here's an example of a patient with LEMS. So you see at baseline, there's, I can't see this, it's about a 50% decrement at baseline. The key features with Lambert-Eaton syndrome is this facilitation or the increment. And you don't need repetitive nerve stimulation to identify this. You could get a single CMAP, have the patient exercise for 10 seconds, give another shock and see what that CMAP does. If it increases substantially, that's suggestive of a presynaptic neuromuscular junction problem. Now, what is the cutoff? It's kind of like myasthenia gravis. There's not a set cutoff. Many people use an increment of 100% as a cutoff, but there are studies, as I've listed here, that show if you lower that threshold to 60% increment, so from the first shock here to the first shock here, then that is significant and has a high sensitivity for Lambert-Eaton syndrome. So what we do is and then the other point is that as I mentioned earlier, the baseline CMAPs are often low. So when you're doing your routine conduction studies, you get low CMAPs, patient who has weakness, that would be a clue that, hey, maybe this patient has Lambert-Eaton syndrome. And then what would you do? You do baseline rep stim, then 10 seconds of exercise to look for facilitation.
Right.
So those are the general criteria. Low CMAPs, decrement at rest, greater than 60% or 100% increment after brief exercise. You can do high rates of stimulation. I think I showed you a picture at the beginning of that. But if the patient can exercise, if they exercise at
with a strong contraction, if you think about when you do our needle exam, the firing rate to those motor units when the patient contracts with a strong contraction is about 25 hertz, sometimes higher. So if they can contract, it's the same thing as, same effect as if you give them 25 hertz stimulation or 40 hertz stimulation, and it's much less uncomfortable to have them exercise.
Well, thank you. We had a few requests. I'm wondering if you would share the slides that you presented. Is that possible?
I can share the ones I showed. I'm not going to show the whole talk, but I can have just the basic concept slides. That's fine.
If you want to just email those to me, I can share them with the participants of the webinar, whichever ones you want to share. Thanks. Well, thank you again for both of your time.